Welcome to Robert Wood Johnson University Hospital's Health Talk. I'm Dr. Douglas Ashinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. Having a baby is one of life's most precious moments. On today's show, we're going to learn more about the team that is involved in ensuring that the mother and baby are well taken care of on that special day. From the beginning of labor to pain management and caring for the newborn, we will give you an overview of what to expect during each stage of childbirth. Today, joining us are three members of the Maternity Child Health Team at Robert Wood Johnson University, Somerset. Dr. Margaret Andrin, Chair of the Obstetrics and Gynecology Department. Dr. Michael Picone, a board-certified anesthesiologist, and Dr. David Sorrentino, a board-certified neonatologist from Robert Wood Johnson Medical School. Thank you all for coming to the show. First, you guys do the most important thing in life. You deliver babies. Tell us a little bit about each one of you, what each one of you likes to do, what made you become what you are. We'll start with Dr. Andrin.
Sure. I'm in private practice and I deliver at Somerset. I also involved in helping to maintain our high quality of care at the maternity and labor and delivery as well. I'm also in-house doctor covering labor and delivery and helping any immediate emergencies and helping the private doctors coming in as well.
Dr. Picone?
I am a doctor of anesthesia. And the reason I went into anesthesia, during medical school you get to experience all the different specialties. I really enjoy anesthesia because we take care of patients when they are at their most challenging, vulnerable situation, and it's very rewarding. So our role in the labor and delivery suite is to help ensure the safety and comfort of the patients that come into the hospital.
And Dr. Sorrentino?
So I do newborn intensive care, and I know Dr. Andrin would say that she has the best job in the world, take care of pregnant moms, but I take care of kids, so I feel like I have the best job in the world. So my job is to help infants transition through their period at birth, and so that initial period in life can be very challenging. Most infants transition without problems, but there's a small percentage that do have problems, and that's when you need a neonatologist. Either they're born early, or they're born with infections, or they're born with some sort of disorder that's going to cause them problems, and that's when we're there to be available to make sure things go smoothly.
So you two can have an argument who has the best job.
There you go.
We'll start with Dr. Andrin. Tell us a little bit about, at the end of 9 months, what labor and delivery is. Tell us what happens.
Well, a lot of times patients ask, how do I know when I'm going to go into labor? And many times we say, you'll know when you go into labor. And what happens is their belly gets really hard and then relaxes and gets hard, and their contractions get more uncomfortable or hours and hours. And we use the rule of thumb, the contractions should be every 5 minutes, lasting 1 to 2 minutes over hours and hours. And at that point, they should be coming in and they will be going into labor. So.
And the stages of labor, just so that the laymen know exactly what it is.
There's 3 stages of labor. The first stage of labor consists of the latent phase, which can go anywhere from 12 to 24 hours in the early stages of labor. And then you have the active phase, where they reach 4 to 6 centimeters, and then which is the active phase of labor. The second stage is when they get to be fully dilated, or 10 centimeters. At that point, they start pushing and deliver the baby. Then the third stage of labor is from the time of the baby's born to the delivery of the placenta, and that's the full 3 stages of labor.
Okay, so a woman, first time she's ever had a baby, is very unsure of what's going on. She's 9 months. We talk about the latency, the first stage, the second stage. Things change. When should she call you? When should she call the hospital? When should she get to the hospital? You know, again, the whole idea is we want her to deliver as comfortably as possible at Somerset, at Robert Wood Johnson Somerset Hospital. And again, they've got the team there ready for you. So tell us what the woman should expect.
Well, we usually tell my patients, I usually tell my patients to call. You know, if in doubt, always call. So if you're not sure, let us know. So I usually tell them if the contractions get regular and more uncomfortable, to give us a call. First-time moms, sometimes they may go to the hospital, they get checked out, still may be early, and they may be sent home, and that's very common and not unusual. So, and it's reassurance from them. Your goal is you want to try to labor home as long as you can, but if you get uncomfortable or unsure, we come to the hospital. We usually call labor and delivery, let them know that they're coming. And then the nurses will check them, or the in-house doctor, which I also do as well, and we would check the patients, see how they're doing, and then they have the option if they want to continue, or if they have any pain, if they need anything extra to get them through the labor, we usually offer them if they want epidural or IV medication.
So let's start again. We're sending them to the hospital. At the hospital, they come in through the emergency room.
Yes.
At the emergency room, they're told that they're in labor and delivery. So they immediately go over to the labor and delivery department, or are they going through the emergency room?
Well, it depends. After 8 p.m., you can go through the ER. So it depends on how they're feeling. If they feel that they're comfortable, they can walk up right to labor and delivery. And then the nurses and the receptionists greet them, and they would get them into the room. They would change, and they would put them on the monitor, and they would check for the baby's heartbeat, and they would also check for the contractions at all. And then they will check to see where they are in their labor.
And it's a team approach at the labor and delivery.
Yes,
Who are they going to meet there?
They'll meet the receptionist in the front, and then they'll get to meet the nurse, and the nurse will bring them to the room and have them change. Sometimes the nurse will check them, or if they need help, we have the in-house, 24 hours in-house physician, and we'll greet them and also take care of them if anything urgent.
And when you say check, what are we checking?
Well, checking if they have any cervical dilatation and to see if they're in labor, and make sure the head's down, and make sure the baby's tracing looks great, and then they will check the contractions and all.
Okay, she's in there, she's going through labor and delivery. She's now developing some pain. Dr. Picone, they're going to call you.
Yes. Well, first, for pain management, there's always non-medical modalities, breathing, massage, music, things like that. In the early labor, some of the options available, the obstetrician may prescribe some IV medication to help with the labor. But as the labor progresses, usually anesthesiology will get a call to come discuss with the patient options for pain management. And generally that involves an epidural catheter.
Okay, so again, we start off again that she comes in, she's used to the pain. She's been through the Lamaze classes. She knows about the deep breathing. Her husband's with her, or her boyfriend, or whoever else is with him. They're going through the deep breathing. She's starting to dilate. It's becoming a little bit uncomfortable. There's a discussion with the obstetrician. The obstetrician then calls you, and then you come in, and again, a discussion about what to do, natural versus medications. Some people opting for the natural, some people opting for the medications. The medications, an epidural means, what does it mean to the woman?
So the epidural itself is a way to give local anesthesia to numb the nerves in the low back that will reduce the pain, block some of the pain sensation that the mother feels during the labor. So there's a lot of advantages to the mother. It helps the mother relax, may reduce the stress hormones that the mother experiences that can be transmitted to the baby. And it makes the delivery process a lot more comfortable, and can provide an additional net of safety too in case a cesarean section is needed. An epidural catheter can be used for the anesthesia for that.
Okay, so the good news is that you're able to allow the woman to become more comfortable so that the delivery can progress well and she'll be in less discomfort from it. And the fact is, being that it's an epidural, it's not going to affect the long-term progress or prognosis of the baby itself.
Right. The idea behind the epidural is the medicine does not go to the baby.
Which is, again, very important that everyone understands that the medicine you're giving is specifically for the mother's comfort. It's not going to affect the baby at all.
Right. They haven't been shown to significantly increase the length of labor either.
Which, again, very important. A woman does not want to be given a medication that's going to increase the time that she's in labor.
So what we do as anesthesiologists, we try to have a quick discussion with the patient, explaining all the options. Generally, epidural placement is quick and easy. We use numbing medicine when we put the epidural in. The epidural is actually a tiny piece of plastic tubing, not much bigger than dental floss. And a lot of times there's less discomfort putting the epidural in than just the intravenous catheter, because we use numbing medicine to put the epidural in. So during the placement, generally we ask the people with the mother, the family, to leave the room. So it'll just be the anesthesiologist and the nurse taking care of the patient, the three of us in the room. And we sit the patient up. We talk them through the procedure itself to relieve their anxiety, and explain what we're doing as we're doing it. And once the procedure's done, we start administering the local anesthesia through the catheter, and we monitor them closely to make sure that they're getting adequate pain relief, and that the mother and baby are doing well, to ensure their safety.
Now, the important thing about what you do at Robert Wood Johnson University Hospital, Somerset, is you are there, or one of your partners are there, 24 hours a day, 7 days a week, unlike many other community hospitals.
Yeah, I think we're unique at Robert Wood Johnson Somerset in the fact that we've made a commitment to the patients and the team to be there 24/7. The American Society of Anesthesiologists slogan is "When seconds matter." Other hospitals don't have a dedicated anesthesiologist. We dedicate a doctor of anesthesia to the labor and delivery suite 24 hours a day, 7 days a week, 365 days a year. At other hospitals, an anesthesiologist may be a half an hour away. That is the standard of care in some respects, but we hold ourselves to a higher standard. We want to do a best practice. We want to be available for the mother and baby, because sometimes there is a morbidity and mortality with childbirth. It's much better now with modern medicine, but years ago it was there is a morbidity and mortality with it. So we try to be there to minimize the bad things that can happen, and be there to ensure the mother's comfort. If an anesthesiologist is not present on site, it may delay an emergency treatment, or more likely it may delay an epidural placement and pain management, where the mother may not be able to deliver with an epidural because an anesthesiologist is not available.
More important, you're on site, which means that it's Christmas and you're delivering, you're there.
Exactly.
You're not having to call the anesthesiologist, who may be an hour away, and then have them come in. You're there at 2 in the morning if someone comes in and needs it at 2 in the morning.
We're there. And that's a service that we feel it's important to provide to the families in our community.
Well, again, better than many other community hospitals which don't have it on site, and even hospitals in New York where everyone wants to go. We have anesthesiologists right there available.
Exactly.
Where many of them don't.
So I would encourage patients that are to be educated healthcare consumers. Go out and talk to your prospective obstetrician and find out what hospital they deliver at, and see if these an anesthesiologist is in-house and available.
And if not, they should consider going to an obstetrician who's part of Robert Wood Johnson Somerset Hospital, who does have that.
Yes, I agree.
And then, of course, since they may be having pain, discomfort, and it's not progressing, sometimes we may need a C-section. Dr. Andrin, tell us about a C-section and why sometimes they're necessary.
Fortunately, sometimes necessary if they go into labor, and we monitor closely the tracing. So if the baby is under distress or has a non-reassuring fetal heart tones, we need to do a cesarean section. Also, if they stop to dilate at some point in the labor, knowing that the baby will not fit properly into the pelvis, so then that's another reason to do a cesarean section. Some patients come in and know they need C-section if they're breech or if they have placenta previa.
Just so that people know what
placenta previa is when the placenta blocks the birth canal, so they cannot deliver vaginally, so they would have to bypass and deliver by cesarean section. And years ago, we used to be able to deliver vaginal breeches, but now, especially for first babies, we deliver by cesarean section because we worry about head entrapment if we try to deliver vaginally with a breech presentation. So those are some indications for cesarean section. And as well as someone comes into labor, if they do not progress in their labor, then we would need to do cesarean section. And if they have an epidural, we use the epidural as their anesthesia, and then the anesthesiologist we work together in making them comfortable for the cesarean section.
So first, so the audience knows what a breech is.
Vaginal breech is when the feet or the buttocks comes first and the head's on top. What we normally want and would like is the head comes first and through the birth canal. And that's the reason why we do cesarean section for the breech.
Okay. And again, the good news is that if you put the epidural into the woman prior, you can use that same epidural catheter for the cesarean section itself also.
Yes. Yeah, we have several different choices for anesthesia for cesarean section. We discussed with the obstetrician, the most appropriate kinds of anesthesia. At times, regional anesthesia is not appropriate, and we need to do general anesthesia. That's always available to us. But there are a couple of kinds of regional anesthesia. We prefer to do them when it's appropriate. If the patient has a working epidural catheter, we'll use that. We'll bolus, give a large quantity of concentrated medicine to strongly block sensation from the belly button down to the toes, and it's very effective. If the patient doesn't have a working epidural catheter and they just come back to the suite for a cesarean, a lot of times we'll do a spinal, which is very similar to an epidural. It's actually a much smaller needle than the epidural needle even, and it's one quick injection, and that lasts for several hours. The advantages of regional anesthesia, whether it's a spinal or epidural, we can give long-acting pain medicine through that injection, and that can last up to 24 hours and make the patient a lot more comfortable in their post-operative course. And the medicine that we give, when we give it in the low back, it causes less sedation and less side effects to the mother, so they can be awake and more alert in the recovery after surgery. Additionally, when we do regional anesthesia for cesarean section, it's very nice because the mother is awake for the delivery, so they can enjoy the childbirth. And we generally we let them bring one family member or support person back to the room for the delivery. So a lot of times as the anesthesiologist, we end up being photographers as well as taking care of mom and baby. So that's very rewarding. But in the recovery room, the mother is awake and can breastfeed, and within a few hours that regional anesthesia wears off and they can begin their recovery process.
Very nice. Now, we'll get up to what the baby's been born. 99.999% of them are perfectly fine.
Yes, the vast majority of infants are going to do well. And I think that's a testament to modern obstetric care. So as pointed out earlier, maternal mortality 100 years ago was on the order of 1 in 10 women died in childbirth, and infant mortality was roughly the same, about 10%. And so now, 100 years later, with the use of modern obstetric techniques and the presence of pediatricians there to help when there's problems, those rates are exceedingly low. Maternal mortality is 1 in 10,000 now. It's a fraction, a tiny fraction of a percent. And infant mortality we don't do as well. We're still a fraction of about 0.1% for infant mortality. And some of that is due to the problems that are identified prenatally. The obstetrician during the pregnancy will do multiple ultrasounds, evaluate the mom and the baby throughout the pregnancy. So in many cases, as a neonatologist, we know that there's potential problems coming. And those are the cases where you can plan things in advance, have everything set up and available at the delivery. And then we can give us optimal outcomes after birth. However, there are sometimes things that happen at the last minute, and that's why it's important to have neonatal services in-house 24 hours a day. And so at Robert Wood Johnson Somerset, we have 24/7 in-house neonatal coverage. So we're there to support the obstetrician in those emergency cases. Delaying resuscitation for an infant or delaying that intervention greatly increases mortality and morbidity. So it increases risk to the baby's life and risk to the baby's long-term health in terms of neurodevelopmental issues. And when I say delaying resuscitation, delaying it as little as a minute can affect that. So it's very important to have your neonatologist there. And although Robert Wood Johnson Somerset is a community hospital, we function in labor and delivery as a university hospital. The staffing that we have there is optimal to provide the best possible care. We're in the Northeast United States, in New Jersey, one of the best states in the country. There is no way we're going to allow things to be anything less than optimal for those infants and moms in delivery. That we don't need to, we have the resources, and we provide that right there. So as the neo, it's great because I get to see the babies first, generally. Well, after the obstetrician, but she hands them off. But then we can help that transition. Whether there are problems or not, we can help the baby transition from the in-uterine environment to life outside of the womb. And that transition, although most cases happens naturally, we're there to make sure that that natural progression occurs without interruption.
And at Robert Wood Johnson Somerset Hospital, we're a level 2 neonatology intensive care unit.
Yes.
Can you explain what that means?
So when you speak about levels of care, it speaks to our ability to provide ongoing care for infants after birth. So at a level 2 neonatal intensive care unit, we can take care of infants that are born up to 2 months premature. You can survive as close, probably as far out as 3 to 4 months premature. We could handle those infants at Somerset to stabilize them, but their long-term ongoing care is very complex, and you need to have them in a more a higher level nursery for the interventions that, for potential surgical interventions, long-term intubations, a lot more chronic care issues. We can deliver all of them at Somerset and transport to a higher level NICU, which would be here in New Brunswick, or would be in New Brunswick if necessary. However, at Somerset, we can do the care for those infants throughout the entire hospitalization as young as 2 months early. So down to somewhere around 30, 32 weeks is where we would have the capabilities to keep them at Somerset indefinitely until discharge home.
And again, 24 hours a day, 7 days a week also.
Yes. And so in order to do that care, in order to have a 32, 33 week or an infant who's 7 to 8 weeks early, you need to have your neonatal services right there to take care of those infants all day, all night. We have specialized nursing staff, specialized respiratory staff, and then physicians with very specialized care. So
the wonderful thing at Robert Wood Johnson University Somerset is we've got the beginnings, we've got the anesthesiologists who help in the middle, and then we've got you who take care of the hardest to treat of the babies.
Yes. And it's, at Somerset, at Robert Wood Johnson Somerset, it's great that we can do that in that community setting. Because it's no fun. We don't want families to be displaced from their local community. We don't want them to have to go to New Brunswick, New York, Philadelphia. We can do everything there and do everything we can to keep them home.
Which again is very important because most of the time the woman chooses her obstetrician based on where they deliver the baby. And again, the whole family's going to want to come to see the baby after it's delivered. You'd like it not to have to travel to New York if you unnecessarily. You'd like it have everything at one specific place.
Absolutely. And in the NICU, we're all about family-centered care, right? The care of this infant is important, but we also have to make sure that the family is dealing with the fear and anxiety of being in a newborn ICU and having them transition to care at home. At some point, that baby's going to go home with that mom, so we have to make sure that the family's ready and the baby's ready to go home.
So again, the whole family situation, the whole team approach at the hospital, the whole idea that it's 24 hours a day, 7 days a week, means that women really should think about coming to an obstetrician who is part of Robert Wood Johnson Somerset University Hospital, because we can take care of them from the beginning through the end and transition them to home afterwards.
Absolutely, and keep them in their local community, which is huge. I mean, birthing is a beautiful, wonderful time. And being able to do that where you're home and comfortable with your family around you is essential.
Okay, so tell us a little bit about someone a baby that you had recently, no names of course, that just so people know what you've done.
Oh, there's quite a few infants I've taken care of.
We've got about a minute to talk about, so just tell us quickly about one special one.
All right. So the one that stands out for me is we had a series of triplets that were born 6 to 8 weeks early, and the mom, the family, the dad were all there throughout the entire time that the baby was in the hospital, and we were able to work with them. And these 3 little guys did very well. No complications. They were early, but we were able to transition them through and do their care all the way through discharge home. And that care wouldn't have been possible as easily and smoothly it was. So your multiples are generally going to deliver a little earlier, but they had great obstetric care. The delivery process was smooth. Mom had no issues around her delivery, thanks to the good work of our OBs and anesthesia. And then we were able to get those babies home with no complications. And they're now. I got pictures of them recently, and that's why I'm bringing them up, because they're over a year now and looking beautiful, uncomplicated, perfect deliveries.
Very nice. So again, the fact that we have the team here, the fact that we have a hospital that does all of this, allows us to take care of the complicated babies, the babies who have the preeclampsia, the gestational diabetes, the early deliveries, the multiple deliveries, the fact that they get terrific they get all the obstetrical care prior to it, that they get the ultrasounds, they get the blood work, that they have an anesthesiologist there 24 hours a day, 7 days a week, allows them the ability to be treated appropriately. And again, the neonatology level 2 unit, which allows us to go through all this, allows us to take a baby that we may know a lot about or may not know a lot about, and get them through the full delivery process in as best shape as possible.
That's correct. And we also have maternal fetal medicine specialists at Somerset that work with the obstetricians that do the serial ultrasounds as well. And in consultation with them, we were able to take high quality care of these high-risk patients as well. So we work with them as a team.
Well, thank you all for being here, and thank you for everything that you guys do to deliver babies, the most magnificent thing in the world.
Thank you.
Thank you.
This concludes today's episode of Robert Wood Johnson University Hospital's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral number at 1-888-MD-RWJUH. For more information about the maternity services at Robert Wood Johnson University Hospital, Somerset, please visit us at www.rwjuh.edu.